Good afternoon, everyone. We are delighted to welcome you to our webinar this afternoon, which to mark National Advanced Care Planning Week in 2024 will be an introduction to advanced care planning for health professionals. My name is Emily Buchanan, and I'm the Primary Care Projects Lead at Western Victoria Primary Health Network, and I will be your facilitator this afternoon. I'd like to begin by acknowledging the traditional custodians of this land on which we're meeting from. For me, I'm joining you this afternoon from the beautiful Wadawurrung country, and I'd like to pay my respects to elders, past and present, and extend that respect to any Aboriginal people present today. Before we begin, just some housekeeping. This webinar is being recorded, and you will be able to access the recording freely on the PHN Learn YouTube channel. We will put the link to access our recorded webinar events into the chat. Following your attendance at this introductory webinar, if you have further interest in developing skills to facilitate advanced care planning, we will be sharing links to a regional training calendar with further educational opportunities. You may be familiar with Health Pathways, the free online resource with localised clinical and referral information for health practitioners. You'll see on the slide here that some of the advanced care planning related pathways that are available. If you've entered the webinar not displaying your accurate first and last name, or if you're tuning in with a group of people, please type your full name of all attendees into the chat box. Only our administration staff at the Western Victoria Primary Health Network will be able to see this, but this will ensure that we can issue all attendees with the certificate of attendance. For this afternoon's webinar, all participants will remain on mute. And if you have any questions, please type them into the Q&A box, and I will ask them on your behalf to our presenter during Q&A time. And finally, there is a link in the chat box to complete the survey after the webinar, and we'll show this slide again at the end of the presentation. Now, I'd like to introduce our presenter for today's webinar, Melissa Couch. Mel is the Advanced Care Planning Consultant and Clinical Nurse Consultant in Community Palliative Care at Southwest Healthcare. I'll hand over to you now, Mel. Thank you.
Thanks, Emily. So thanks to the Primary Health Network for today. I hope everyone learns something new about advanced care planning, and hopefully we make today's session easy to understand and applicable for wherever you may be joining us from. So hopefully today we'll learn a little bit about what advanced care planning is, identify opportunities for where you may be able to bring up advanced care planning in your health facility or organisation. We'll talk about some of the legal and ethical implications of advanced care planning, because they are often legal documents, and hopefully increase your confidence to support people in able to complete advanced care plans or know where to get the appropriate documents from and where those resources are. So in a nutshell, advanced care planning is really just the process of planning for future health and personal care. It's when you may not be able to speak for yourself. Now, whether that's a short-term decision-making issue or whether it's more long-term, such as a dementia. And I guess the main thing is if you cannot speak for yourself, who would speak for you and what would you want them to say? We do have a video that's available. Emily and the team will put a link into this chat about the one that's on your screen at the minute. It goes for about 5 minutes, and it's a really great introduction to advanced care planning. It's often one I actually show some of my clients as well. I think it's a really easy to understand, and it's something that everyone can relate to video. So advanced care planning in a nutshell, it's really if you are unwell and unable to make decisions for yourself, what are your preference for medical treatment? One of the things is how do we know that someone might have an advanced care document? Where is it? Where can we store it as health professionals? And one of the big ones that I think is vital is who is the medical treatment decision maker? What's their role? And do they know what their role is? And then what are an individual's values and preferences for medical care? So advanced care planning is across all Australian domains. Today we're focusing on Victorian legislation. So in Australia, we can identify who someone's medical treatment decision maker is, or appoint their substitute decision maker. And we can also then look up what their preferences and values are. And in Victoria, it's an advanced care directive. So if you go onto the Advanced Care Planning Australia website, there are lots of informations for individual states and territories. All the resources are available on there. There's lots of information. They have also a advice line that anyone can ring Monday to Friday. So we are just mindful that an advanced care directive that might be done in Victoria will apply in all other areas of Australia. However, they may have some limitations or additional requirements if they are required to be utilised in other states. So we'll just go through some of the benefits of advanced care planning. Obviously, the main one is for the person. It's that person-centered care. It's about what's important to that individual. And it helps ensure that that person can receive the care that is consistent with their values and preferences. Quite often, especially in the hospital system, if someone comes into the hospital, we may never have met them before. So it's really hard if that person can't speak for themselves, too important to them on an individual basis. And I guess that's where we always come back to that holistic care of the person. It's about what they want to receive or what they would like done on their behalf. For a substitute decision maker, the benefits of advanced care planning are that it reduces anxiety around making decisions on behalf of someone. So quite often we don't actually talk about a lot of our preferences for medical treatment for whatever reason. Sometimes we're a bit nervous about bringing it up with our loved ones, where we can be worried about upsetting them and things like that. But if you are someone's decision maker and you're expected to make decisions on their behalf, and quite often it can be under stressful and acute circumstances, being able to have already previously had a discussion or be able to look up an advanced care directive to clarify someone's preferences for care can really reduce a person's anxiety around making these decisions. Quite often we hear after the fact that the substitute decision maker didn't know what the person or their loved one's wishes were, and it was really quite stressful. And that can be a long life guilt that they quite often experience if they haven't actually spoken to their loved one. For healthcare professionals, we want to respect people's wishes around their medical preferences for care. And quite often it's hard for us if we don't have a clear pathway and we can't speak to the person and get their perspective to find out and truly respect what their wishes are. So having an advanced care plan, especially if it's documented and held on file at a hospital, is really valuable in able to determine ongoing care planning and management of that patient once they come into our care. And for the health service as a whole, it does reduce having non-beneficial transfers to acute care. So that might be from someone who is in an aged care facility and, they might be quite old, they have lots of comorbidities, they might have a short life prognosis. And for them coming into hospital and having unnecessary treatments and investigations can actually be weighed well against what it is that that person believes in. And also we don't want to be putting people under stress and exposing them to interventions that may not have a benefit and may cause that patient unnecessary stress. So making medical treatment decisions, it's a huge responsibility, especially if you're doing that on behalf of somebody else. So in the health industry, health professionals, they will decide or determine what treatments are indicated. And in conjunction with the person where they can, or the medical treatment decision maker, those decisions or treatments will be offered. Health practitioners are not required to offer or administer non-beneficial treatments. And a lot of people aren't aware of this. So health practitioners do not have to offer treatments that may or most likely won't have an optimal benefit for that patient. So for example, that might be someone who's 95, they might have advanced dementia, have significant heart problems. If they were to come into hospital suffering a heart attack or to have a cardiac arrest, a health practitioner may deem that it's not beneficial to offer such things as resuscitation, because the person may experience extreme negative outputs from that, and it's obviously maybe not what is in the best interest of that person. So if a person has capacity, they make the medical treatments decisions themselves. It's only when they don't have capacity, and that sometimes can be a little bit of a grey area, but we have to determine that the person has capacity to understand the information or the treatments that are being offered to them. So if they don't have capacity, then we go to their advanced care directive and take effect to guide decision-making in the healthcare organisation. So capacity to make decisions, normally we would presume that a person has capacity. Really, it's up to the health practitioner to decide what level of capacity that may involve. We really should be involving all patients, no matter what their capacity, in all decision making. So some patients might have early onset dementia, so they may have, good understanding of some of the treatments that might be offered. They can make simple decisions. However, they may not be able to understand more complex decisions. So that's when we might involve a medical treatment decision maker to help interpret those decisions and help make decisions for that person on their behalf. So to make their own decisions, a person must be able to, one, understand the information about the treatment or procedure that's being offered. They have to be able to remember the information long enough to make a decision, and they have to be able to think about and weigh up the pros and cons of those treatments or procedures being offered, and then be able to communicate that decision. So there is a bit involved in being able to, have capacity to make these in-depth decisions. So it might be a simple thing that a patient comes in, they've got dementia, they can generally recommend or acknowledge who their medical treatment decision maker is, and it might be a special loved one, a child or their partner, and they might be able to say, look, I'd rather that you speak to them, so they can understand that that person is their appropriate decision maker. But then if we're looking at offering a big surgery intervention for a patient, they may not be able to understand, well, okay, my stomach's in pain, I'm going to have this big surgery, but what are the outcomes or the risks associated with that, having that procedure done? They may not be able to put reference into, okay, if I have this big surgery, I'm going to be in hospital for a long time, I may not make it out, I'm exposed to more risks because of that surgery, and what the implications for that might be. So if that person can't make the decision, then the doctor will refer to the medical treatment decision maker. So some of the things that we look for in conversation triggers are obviously when a patient requests information about advanced care planning. We look at also in a general practice scenario, it's quite often associated with a medical assessment such as 75 Health Plus assessment, which is done in general practitioners' offices. A significant change in life circumstances, that might be the death of a spouse or a partner, a special loved one. They might be looking at going into aged care facilities, discharged from hospital. Someone might be having regular admissions to hospital. And we need to start looking at, well, okay, what's brought them in? What are we doing? And what's the plan moving forward? Obviously, the diagnosis of a new disease, whether it's chronic or terminal, we should be looking at advanced care planning. As Em said before, I work in palliative care. So for us in palliative care, our patients have a prognosis of anywhere to, up to 12 months. So we like to talk to them very early on in their journey with us about what some of the things are that they would not want if they came into hospital. And that might be things around resuscitation. It might be about having chemo. Sometimes someone might have chemo and it might be that they are given an extra 3 months, but the side effects of that chemo are that, they suffer significant symptoms associated with that chemo. And so they sometimes have to weigh up, well, has that really affected or made a positive influence or effect on my quality of life? So all chronic disease management, that's a huge trigger for looking at an advanced care planning conversation. So quite often chronic disease, in and out of hospital, and at what point does the patient say, well, I want to change from this trajectory to another trajectory? Especially to the people who are at early onset dementia or at risk of losing capacity, because advanced care planning, if done on the legislated forms, then you have to have capacity to be able to do legal advanced care planning. So the earlier we can get people who are at risk of losing capacity, the better, in order to develop these documents. And as I said before, proposed admission to a residential aged care facility is a huge trigger for looking at advanced care planning. So the advanced care planning process and conversation, generally you'll introduce the topic, and sometimes studies have been shown that healthcare professionals sometimes are a bit nervous about bringing up or introducing advanced care planning because they're a little bit worried about upsetting patients. And the studies have shown that patients actually are hoping that we'll bring it up, because sometimes it's too hard to talk about with their loved ones because they're worried about upsetting their loved ones. So, as health professionals, we really need to be confident about bringing up a lot of these conversations, because, usually you're the facilitator in able to facilitate the conversations between patients and their medical treatment decision makers. As I said before, the main thing I advocate is who will speak for you. Sometimes we think it's those that are closest to us, whether that's our spouse, our child, sibling, and sometimes we have to realize that those people might actually be a little bit too close. Could they actually make really hard decisions for someone in an acute or emergency situation? And I don't know how many people out there have had to do it, but from the people I've spoken to, it's actually really stressful to make those decisions. And sometimes you might be making a decision that inevitably will be reducing that person's lifespan. So it's a huge burden sometimes for people. So it's important that we really have an in-depth conversation and work out, well, who is the best person to be your medical treatment decision maker? And then what are your individual goals, values, and beliefs? We all are extreme individuals, and how do we get that across to a healthcare team? And I guess that's one of the big things about writing down your wishes in an advanced care directive. My beliefs and wishes may be very different to the person sitting beside me. But unless we've written it down, how would someone know what those beliefs and wishes are? I like to think, I always say I'm still quite young, fit and healthy, and I've written a very clear advanced care directive. For me, I find it comforting to know that there is a document there that speaks to who I am as an individual and what's important to me in living a really good life. And then obviously we go more into care and treatment preferences. So that's more talking to medical treatments and might be more specific medical treatments. So as I said before, it might be someone who's facing a short prognosis with a terminal cancer, and they might talk about, okay, at what point do I stop doing treatments or chemo or radiation, or, what other things might I be prepared to have a look at and going forward with? And how do we conclude the conversation? Quite often, there's many people who are involved in an advanced care planning conversation. It's not just one person. It might be the nurse on the ward who gives out the document to a patient whilst they're having an inpatient stay. Then it might be, contact your GP clinic. You might speak to a practice nurse there. Then you might speak to your doctor about their input around what your current medical situation is. And then how do we conclude it all? How do we finally get the document to arise, and where does it go from there? So I guess one of the key things about that is documenting. If you have clinical records, making sure that we're documenting where we're at in that space. So for me, myself, when I get referred patients, I have a clear plan about what we're doing. We have a follow-up. And then if that person presents back to hospital, somebody who's looking after them on the wards can say, hey, you've had a conversation with Mel, you looked at doing your advanced care directive, did you get it done? Yep, great, the GP did it. We haven't got a copy, can we get a copy? So I guess it's about closing that loop. So some practical tips. Often this is the big one. People don't know where to start. It's such a, sometimes, it's a big thing to think about advanced care planning and how do we start? Where do we go at the very start of our conversations with that? So sometimes it might be looking at someone and saying, okay, what's the most important thing to that person? What makes every day a good day for you? What do you value or enjoy most in life? And quite often the conversations aren't actually about medical treatments or preferences. It's about what is a good day for that person. Have they got anything on their bucket list that they want to try and achieve in their life? And what might they be prepared to do or compromise in order to make that happen? Have they got any cultural beliefs that are important to them and it might be worthwhile for your health carer to know about that? Where would you prefer to have your healthcare? For some people, it might be really important that they have their end of life in a hospital. For others, it might be to have that at home supported by family. What are the most important things that you would like known and who would be the people that you would like involved in that care? What would be some unacceptable health outcomes for people, and that might be things like, if I couldn't use my brain to make, simple decisions in my life, such as putting some food to my mouth or recognizing who my loved ones are, that might be an unacceptable health outcome. For others, it might talk more about their mobility. I might find it acceptable to be in a wheelchair for a long-term prognosis, but someone else may not. I may find it unacceptable to be bedbound for the rest of my life. And we talk about things in short term versus long term as well. I think that's a really key aspect. Some people would have a different scenario around a short term outcome as opposed to a long term outcome. And what might be some of the treatments that you would not want if there was little chance of recovery? So I guess it's about choosing quantity and quality of life. Some people sit on the quality side of life, and then there might be others who sit on the quantity. They want all attempts at life preservation, no matter how old they are. So everyone's a really different individual when it comes to having the conversation and what's important to that person. So when I talk to people, I like to break it down a bit more simply, I guess, and what would be acceptable to you. And I talk about lines in the sand. Most people understand the concept of where your line is in the sand. And for me, I talk to people about thinking, where's your line in the sand about being able to think for yourself and what might that look like? And sometimes just saying, I don't recognize my family and friends isn't enough. We need to talk about, well, what about if I don't recognize them for majority of the day and I can't love and laugh and interact? Talking, at what point is that important to someone in their life? And I always joke around and say, if I couldn't talk, I'd probably be in a lot of trouble because I love to talk. A little bit the same with eating. Some people, it's not a big deal. For me, I talk about things in my care plan about, eating represents family and love and gathering. So for me, the enjoyment of eating and having others participate with me in doing that is what I value in life. So when we talk about that, it might be, okay, would I consider being fed through a peg tube? At what point would I say, okay, I don't want to be force-fed in order to be kept alive? So, we can talk about what does that look for you. Walking and mobility are often a big one for people. At what point is being unacceptable in terms of mobility? For a lot of people, they say being bedbound ongoing and all the time, relying on machines to get them in and out of bed. But for others, it might be, okay, well, if I've got my brain and I can think for myself, I might accept physical limitations and get others involved to help me out. It might be coming and giving me a shower at home. So we need to break down what would be acceptable and what's not acceptable. And they're the kinds of things that we start to document in our advanced care plan or directive. So when we've done the documents, what do we do with them? A lot of people have them at home, or they might be sitting in a GP clinic. It's important that all advanced care planning documents are current, they're accurate, they're all complete. There are some witnessing requirements to advanced care directives to make them legally valid, and that they can easily be accessed at any point of care in a journey. So for a lot of people, they don't realize that, you know, they really need to be at the hospitals. And it might be multiple hospitals. A lot of people don't also realize that we all have different health record systems. So sometimes that might be my education about, okay, you might have your document at my hospital, but do you have it at the local St. John of God? Because we don't share the same system. So sometimes it's as easily as, okay, can you bring the document in? We haven't got it on file. And then knowing where to store that document. Most electronic health systems in the hospital setting will actually have dedicated spots in those health records that we can store advanced care plans and easily find them when we need to find them. So we always recommend that the patient keeps their original document. If I'm doing an advanced care consult for someone, I usually provide them with 4 or 5 copies, and that might be then to give one to their GP. Any other hospitals, you can upload them to the My Health record. If you're moving into a residential aged care facility, make sure that they have one. And sometimes even for our palliative care patients who quite often might want to die at home and may have to call an ambulance, we actually ask them maybe to keep them on the side of their fridge with their medications. So if an ambulance was called and it was more because they're in a pain crisis, they know that, okay, they really want to avoid coming into hospital, that they would like to try and have their needs met within that home. Might be that they don't want resuscitation, all those sorts of things. So it's really handy that if a patient does maybe have a life-limiting illness, that they have them easily located for an instance where you might have to call an ambulance. So copies of the advanced care planning documents should also be shared with your appointed substitute decision maker. By giving them your advanced care directive, it gives them an opportunity to be able to ask questions about what's in the advanced care directive. For anyone that's had a look or is familiar with the advanced care directive documents, they're only little boxes. So there's only so much we can put on that bit of paper. So sometimes we might need to tease out things, and that's done more through open conversations. And it's really good to also then let your family, friends, and loved ones know. Quite often when someone comes into the hospital, we're dealing only with the substitute decision maker. You know, we only ever get or have one decision maker at any one time. So sometimes family and loved ones can get a little bit upset when they're not included in that process of decision making. So the expectation is that the substitute decision maker goes back and shares that information with those important people in that patient's journey. But it's good to let the family and friends know, okay, well, I've chosen my eldest daughter, she's my spokesperson if we come into hospital, so that there's no dispute or upset, I guess, when people come into hospital, because we often see that. You know, one family member may not have known that their mum had chosen a specific decision maker, and it can all seem like they're being shut out. So it's really important to be open to those in your significant network. Obviously, your doctor or specialist, it's important that they have copies of these documents. Emergency services, such as AMBOs, they do sometimes recommend that they'll check sides of fridges for any important documents. And obviously the hospitals and residential aged care facilities are the main people that have these documents. So it's worth noting too that if you do appoint a medical treatment decision maker as part of estate planning with a lawyer, that also gets shared with the same people that we've just mentioned, because it's really important that from especially a hospital perspective, that we have these documents on file. We can't take someone's word that they have been appointed legally. We must have that document to support that, obviously because it's such a big role that that person's being given. Sometimes people have made false claims that they are the substitute decision maker when in fact they haven't been. For whatever reason. So it's really important that we get copies of those documents to health facilities. And sometimes that's where GP clinics play a big role. They might be actually completing the documents. I know here locally, we have a lot of our GP clinics who will actually forward a copy of a completed advanced care directive once it's been finished and witnessed. We also have some local lawyers who do the same thing, and that's really great, identifying some of these key people within your networks and having a bit of a standardized system about how we make this easier for the patient, because at the end of the day, sharing these documents is in the best interest of the patient with their consent. So Victorian legislation, we have the Medical Treatment and Planning Decision Act. So this covers all things regarding advanced care planning. So in Victoria, you can choose and appoint a medical treatment decision maker. So in past, you may be familiar with an enduring power of attorney, medical. That is still valid. Although being now that the Act has been in place since 2018, quite often it's a good opportunity if you've got a medical enduring power of attorney to have a look, make sure that the people are still valid and relevant medical treatment decision makers, that we've got up-to-date information such as mobile phones. There's a bit of a difference in the documents. The medical treatment decision-making forms will actually include that person's address and their phone number, which makes it really more valuable to, say, a healthcare facility, because then we can update that person's medical record and make sure that we've got the correct information, because quite often things go a bit pear-shaped out of hours. So to have correct and up-to-date contact information is really important. And then you can make an advanced care directive. So it's either a values or instructional, and we'll go through that a bit more clearly, and also appoint a support person. That was sort of a new appointment under when the Decision Planning Act changed in 2018, what came into effect. So what are health practitioners or health professionals' responsibilities with regards to advanced care planning? In Victoria, all registered health practitioners are obliged or have to make a reasonable effort to determine if a person without capacity, one, has an advanced care directive, and two, to identify medical treatment decision makers. So with that, that's where it's really good to have systems in place within your organisation to identify who the medical treatment decision makers are, and you can obviously have more than one. So it's important that you've got the ability to be able to clearly identify who these people are and where the information is going to be held. You might need to access some of this information in quite a quick turnaround. It might be that someone presents to an ED, they're having a major stroke. So we need to be able to act on and find these advanced care directives very quickly to make decisions. Need to move, my light's going off here. So with that, we also, from a healthcare organisation, need to provide information about advanced care planning. So that might be simply just handing out some documents. It might be pointing someone towards the Advanced Care Planning Australia website, or it might be referring back to a GP to assist someone in developing an advanced care planning document. So we also have to encourage discussions and record these conversations, and quite often in detail, about what that patient might have suggested or spoken about to a doctor. In here, we call it a resuscitation plan at our hospital or organisation. Some other facilities call their documents or have an avenue to document goals of care. So when a person presents to hospital, we need to make sure that we have captured goals of care for that patient. So we might have the young, healthy person who is, going to probably make quite a expected recovery. So you might have goals of care that are stating that they are for resuscitation, they're for all attempts at life-saving, they're for all medical treatments that are offered. But then you might have at the other end of the spectrum, someone who's coming in for end-of-life care. You know, they might be for comfort care and pain management only. So we might say that their goal of care is, we refer to it sometimes as a C or D, which is, you know, we're here not to resuscitate them. We might not even be doing OBS on them some days. We're just here to make their end of life care the best that we can and relieve those symptoms associated with the dying process. And so then we need to capture those discussions and record that within our health record system. As I said before, we identify a medical treatment decision maker. So someone might have multiple medical treatment decision makers. Then we need to determine the order of those decision makers. We might have someone who's just their contact person. And the difference with that might be I have an appointed medical treatment decision maker who is there to make my medical decisions, but I might have a contact person who is important to me, but there's someone we can contact to come and pick me up from a hospital admission. They're not necessarily someone who they won't be making medical decisions on my behalf. And we need to identify that if we've got existing documents on our records, what they are, what the relevance is, and also what the legal connotation behind them is. You know, have they been witnessed accordingly? Is it something that is legally binding? So we need to really know about a lot of those types of things. So in Victoria, your medical treatment decision maker, and generally we'll all have one. It's just a matter of whether they've been legally appointed. You as the person might have nominated who you want that to be, or there may be people who don't have an identified medical treatment decision maker. And in that case, we are bound by legislation in order to find out who that best person should be or might be. So the role of the medical treatment decision maker begins when the person loses decision-making capacity. And they must make a decision that they believe the person would have made themselves. So we're stepping into the patient's shoes. We are making decisions in what we believe that person would have made for themselves, not what we as the decision maker think is the best thing to do. So they may be appointed to the role formally by the person on the legal document. They need to accept that responsibility. So now on the medical treatment decision maker, you actually have to accept that role in writing and get that witnessed by someone. And you can only ever have one person act in the medical treatment decision-making role at any one time. And a lot of people don't know that. I'll often have families who say they want to nominate all their children, and they might have 4 children. So I have to be very clear about, okay, the order that you put them in on the document, because the person that you have as one is the ultimate decision maker. They may go back to the rest of the family and discuss what the treatment options are, but we only as health organisations need to go to that one person who is acting in that role. So for a lot of people, they might have 2. And the benefit of having 2 decision makers is that your first one might be your spouse and you might be in an accident together and you both haven't got decision-making capacity. You then can have a second one, or your first medical treatment decision may pass away. So then you've already pre-organised to have a second person. They may be overseas. We can't get in contact with them. So we've hence got another second backup to this role. Or, as I said before, it may be identified via the legislation. So this is the medical treatment decision-making hierarchy that the legislation has stipulated. So anyone who is appointed a medical treatment decision maker, or in the old enduring medical power of attorney, they are the number 1 decision makers. That's who we would go to first in the event we need someone to make a decision. Then we can go to a guardian who has been appointed by VCAT. Then for most people, those without any legal documentation, it's the person who's in the first and of this following list, and they must be in a close and continuing relationship. Now, the legislation goes into quite significant detail about what this looks like and what these relationships look like. So your first one is your spouse or domestic partner. Now, there's also quite a significant definition with regards to this. So it could be your spouse or domestic partner. You may not even live together. You might be in an inferred relationship. So you need to really think about who the right person is for your medical treatment decision maker. Then we go to a primary carer. So that's not someone who works at an aged care facility. That might be the mum looking after her adult disabled child. They would be considered that primary carer. Then we go to adult child, parent, and adult sibling. Now, it's worth noting if there's multiple primary carers or multiple adult children, we go from the oldest to the youngest. So I hope you're all sitting here watching this, trying to figure out who your person is. And I suggest that if it's not how it's listed in this order, you might need to start considering about looking at who would be your person. So I always use my own example. My spouse, he has said that he would prefer not to do this. He thinks he'd probably be a little bit too close to the situation, and he's been able to recognise that he might make decisions that are actually best for him. So I have appointed my sister. I'm very lucky that she's also, she works in healthcare as well, and she's got a good insight into me as a person and what living life well means for me. So it doesn't necessarily have to be someone in your family either. So if it's a very dear friend, obviously they don't sit on that list. So it's really vital that you go and have them legally appointed. So before, as we said before, the medical treatment decision maker must make decisions that they reasonably believe is what that person would have done for themselves. They can consent or refuse treatment on behalf of that person who has lost capacity. So it's a huge role that person plays. They can consent or refuse treatment. So it is quite, it's a really big deal for that person. So that's why we want to make sure we get the right person who has a good understanding of the client or the patient that needs that decision made for them. They must be reasonably available and willing and able to make the decisions. So I talk to my patients a lot about who can we contact, who will answer the phone. We like to promote that the person is maybe local to that person, but sometimes it doesn't matter. So long as we have a mobile phone, they're going to answer the phone generally in a reasonable time. Sometimes I might have patients who say they were looking at someone who might be a fly-in, fly-out worker who doesn't rarely have their phone with them. So I might talk to them, okay, is this person really the right person? Because if we can't get in contact with them, then we have to resort to other means in order to make decisions. When we complete the MTDM form, they must be completed in English. We do have provisions for interpreter and translation resources are available on Advanced Care Planning Australia's website. They must be witnessed by 2 adults, and one of these witnesses must be a medical practitioner or someone who can witness an affidavit. The second witness cannot be either of the people who have been appointed if there's multiple MTDMs appointed. There's no limit to how many can be appointed, but obviously we use the numbering in which they've ordered them in on that document. So some of you might be familiar with what we now term next of kin as being the old terminology that we use. This is really no longer used in healthcare. It doesn't really have any legal connotation to it. So we've shifted to using the terms medical treatment decision maker and their order and whether they've been legally appointed. So next of kin doesn't really play a role in determining who someone's substitute decision maker is. So just be aware of that maybe if you're looking at your own processes or procedures, and just look at some of the terminology that you might be using or you may need to update. So as we said, the person who can speak on behalf of someone who does not have capacity in Victoria is called a medical treatment decision maker. So these, for those who aren't familiar, this is an advanced care directive. Within that advanced care directive, there's 2 parts. There's the values and the instructional directive. So the values is more directed at your medical treatment decision maker, and the instructional is directed at your doctor. It's a legally binding component of the document. So the values might talk about what's living well to you and some more generalized comments, whereas the instructional is legally binding, and that's specific instructions to a doctor. So it might be, I consent to IV antis, I consent to blood products. It also might say, I refuse resuscitation, I refuse being on a ventilator, I refuse chemotherapy. So it's very specific. So the Advanced Care Directive can only be completed by a person who is deemed to have capacity, because they are actually writing down some complex scenarios. So they need to understand what it is that they're writing down. They must be written in English, and they must be witnessed by 2 adults, one of which must be a medical practitioner. Because we're talking about medical scenarios, we need to know that the patient has a good understanding about some of the decisions they might be contemplating or looking at recording on that Advanced Care Directives. So with the values, the emphasis on because it's because of what's important to me. It's what if. It's not so direct. It's, you know, if this happens, this is how I would feel. Whereas, as we said, the instructional directive is legally binding, and it's because of a circumstance, we must act on it. So in Victoria, we also do have forms and resources for people who don't have capacity, and that is the document that's available from the Office of the Public Advocate. So people who don't have capacity or who may not have been able to write an Advanced Care Directive may be able to complete this document, what I understand to be the person's preferences and values, and this can be completed by the MTDM and the family. And this is really valuable for someone, especially if they might be entering an aged care facility, that we can still capture what was important to that person, and there's still you know, a document that exists that captures that person's wishes around their preferences for medical treatment. So then we have finally the support person. This is a person who has decision-making capacity to make this person can help support a person to make decisions. They can have authority to access certain health information. They can't actually make decisions on a person's behalf, but they can help support them to make decisions. Or it might be someone who is local, say my nana, my sister might be the medical treatment decision maker, but I'm more available to take her to her appointments. It might be the dentist or the GP. So I can have a little bit more access to her healthcare and help her you know, understand basic information, but I'm not there to make a decision on that person's behalf. You can only ever have one support person at any one time. They can't, as I said before, make decisions on that person's behalf, and you still must get that document witnessed appropriate by the same as who would fill out an MTDM form. So after this, you want any more information, Advanced Care Planning Australia have lots of resources that are available online. As I said, they have the National Advisory Service that you can ring. Quite often with major hospitals, there's someone like me who you can ring and talk to, and there's referral networks that are available that you can link back in, and also your GP is generally your best place to start. And I thank you all, and I hope you've learned a bit more today, and I welcome any questions that will come back, hopefully to you, Emily.
Thanks very much, Mel. Now to our audience, now's your opportunity to ask any questions. We have a couple here, but if you would like to ask a question, just type it into the Q&A box and I will ask Mel on your behalf. So Mel, one of the questions we've received is whether advanced care planning overrides, now it says MPOs, but I'm presuming that's medical power of attorney, unless you know another acronym for that.
So as I said, if you've got an Advanced Care Directive and you've written a specific instructional directive, that overrides a medical treatment decision maker, because that's legally binding. So if, and maybe we can even attach the links to some of the documents, but they are available, as I said, on Advanced Care Planning Australia. There's a section specifically related to the instructions, and that overrides anyone else.
Excellent. Thank you, Mel. We've just had another question about the recording, someone that would like to watch this back. Yes, the session is being recorded, and following the session, you'll receive an email that will have some links to where the recording will be posted once it is ready. So thank you for the question. Mel, also, I just wondered if you'd like to comment on, I know I've heard from other health practitioners that often they'll have a patient or a client that they're working with come to them and say, how do I go about this advanced care planning? What are some sort of first steps that a health practitioner could do to kind of direct someone to where to go to find out more and take the next steps?
So if it's me and I get a first initial contact, I generally provide the two documents, being the MTDM form and the Advanced Care Directive. I might link them in with Advanced Care Planning Australia's website. There's also My Values, which I forgot to mention. That's a validated tool that people can actually go on. Anyone can develop and My Values, and it goes through, I think it's 16 life values questions, and you can actually tick the box where you sit on the fence, I guess, or where your perspective is. And at the end, you can actually get that to populate into an advanced care directive. So a lot of people can do the work themselves and then present it to their GP or doctor to help have more further input into. But I guess I always like people to read through the questions first and have a good look and maybe make some notes about what it is that they might feel really strongly about, and then I can help them tease that out a bit further.
Great, Mel, thank you. We've received another question. If a person's been diagnosed with dementia, are they still legally allowed to make decisions? And then there's a comment that, yes, they're currently able to, but when are they deemed not able to? Where is that line?
Yeah. So as I said, sometimes this can be a little bit of a grey area. The law would state that a person has capacity until proven otherwise. So if we had concerns about capacity, then we would have to undertake or engage a more specific capacity assessment. So we sometimes will determine that a patient might have limited capacity, or they might have a lot more capacity. So as we all know with dementia, sometimes it can be about the timing of the day when we have the conversations. So if we go back to what we spoke about, there are elements to capacity that they have to be able to retain the information, they have to be able to recall, and they also have to be able to weigh up the risks and the benefits. So sometimes that's about, it might be a surgeon looking at planning a surgery that they've actually talked about the risks and benefits and got the patient to ask back, have you got any questions? Do you understand what this looks like? So sometimes it's about us questioning the patient and learning, can they answer the questions accordingly? But, capacities sometimes can be difficult to determine. Sometimes we'll actually get a specialist geriatrician to have some input to they might be a new diagnosis of dementia. Sometimes we have patients who have been happily living independent lives with dementia, and it might be that they're getting a bit dangerous, that we might try and engage a specialist to do a proper assessment around that.
Fantastic. Thank you, Mel. Another question here. Is the My Values tool found on the Advanced Care Planning website?
Oh, good question. My Values is a separate entity. If you just type that into your Google search, it will come up. It's actually it was developed by Bowen Health and an ICU specialist there. Yes, I can't think now whether it's on Advanced Care Planning. I know we promote it within Advanced Care Planning, but it is My Values that you can type in and it'll come up. It's got a green logo.
Excellent. Thank you, Mel. The next question here, is there any more sort of detailed brochure that people can give to patients during a health assessment? So I guess just sort of resources and handouts that are available.
There's ones that the government have used, which anyone can go online to the Department of Health. They have a general brochure that we use here at Southwest Healthcare, and it's then got my details. So that's with GPs could use it. There's a little spot there that you can put if you have a specific advanced care planner. You might be able to put their contact details in there. There's an edited version. Otherwise, there is a lot of information on the advanced care planning website for individuals specifically that they can work through, some workbooks and things like that. best place is start with Advanced Care Planning Australia. Heaps of work, heaps of resources.
Excellent. Thank you, Mel. Another question we've got here is, what if the resident, so I imagine this is in an aged care setting, has lost the capacity and has a medical treatment decision maker, but the medical treatment decision maker overrides the advanced care directive since it's a dilemma to the health practitioners? What should they do next? So where there's that.
So as I said before, if it's an instructional and it's been witnessed, then that legally overrides the medical treatment decision maker. If you ever have any problems and it can't be solved within that organisation, you can make applications to the Office of the Public Advocate's Office to help have input into a specific case. Now, that might be you're worried about that person's or the medical treatment decision maker's decision process. And sometimes we do see that. Sometimes decisions are poorly made, and that's for whatever reason. Sometimes it can be money motivated. If you do have concerns, you can actually escalate things through the Office of the Public Advocate and ask for an investigation. And it might be that then they will determine whether the right medical treatment decision maker is actually involved in that person. But once again, if you have worries about that, documentation is key. Document if you have concerns about whether it be elder abuse and things like that. But there are laws around the instructional directive. If it is believed by the health practitioner to be valid, then that's the one that takes effect.
Thank you, Mel. And we've just had someone put the My Values web link into the chat, so I've just passed that on to everyone. So thank you. Thank you for that. We're going to need to wrap it up there. It's been great to have the questions. Thank you very much, everyone. I'd just like to remind everyone to please take the time to complete the participant evaluation survey, either via the QR code, which will pop up, or there will be a message that you receive after the webinar ends. So thank you, Mel, very much for sharing your time and expertise with us all. We really appreciate your contribution to supporting advanced care planning in our region. And I'd like to thank all of our attendees for your time this afternoon as well. Once again, if you have further interest in developing skills in facilitating advanced care planning, we'll be sharing links to a regional education calendar in the post-event email with some further education opportunities. Thank you very much, everyone, and enjoy your afternoon.